Hello friends, so today we have a new topic which is about amiodarone. This drug comes under the classification of drugs of antiarrhythmic. So we will discuss this among the following points into introduction, mechanism of action, indications, dose, side effects, drug interaction and contraindication. So amiodarone. Okay. So first of all, this is the one of the most common used antiarrhythmic drugs. So let me tell you, arrhythmia means the abnormality in the heart rate. Like if it is on higher side, then it is called tachycardia. Or if it is lower limit, lower than normal, then it is called bradycardia. So this is given in arrhythmias. While the United States FDA has labeled amiodarone for the treatment of life-threatening ventricular arrhythmias, the drug is commonly used off-label to treat supraventricular tachyarrhythmia such as atrial fibrillation. Okay, so and also for the prevention of ventricular tachycardias in high-risk patients. So to treat SVT and for the prevention of VTs in high-risk patients. Okay, okay. So about the mechanism of action. So amiodarone primarily works by blocking potassium. So this is so BPO means third class 3 antiarrhythmic. Okay. So by blocking potassium rectifier currents that are responsible for the repolarization of the heart during phase 3 of the cardiac action potential. So what ultimately it will do after blocking the potassium rectifier currents, this potassium channel blocking effect results in increased action potential duration. Okay, and other thing is prolonged effective refractory period. So this amiodarone drug does two things. First of all, it increases the action potential duration by working on the potassium channel, and prolongation of the effective refractory period, so that the cell gets excited and gets action potential with delay. In cardiac myocytes excitability is decreased, preventing re-entry mechanism and ectopic foci from perpetuating tachyarrhythmias. Electrocardiographic evidence of these effects is evident as prolongation of the QRS duration and QT interval. So the bullet points we have to remember is this is class 3 antiarrhythmic drug, class 3 antiarrhythmic, and it works by blocking potassium channels, which is the phase third of action potential. So thereby it increases the action potential duration and prolong the refractory period. So prolongation of QRS duration and the QT interval. So coming to next slide, this we have discussed. Sodium channel blocker is class 1, class 2 is beta blocker, class 3 is potassium channel blocker, and class 4 is calcium channel blocker. So coming to slide. Unlike other class 3 agents, amiodarone also interfere with beta adrenergic receptors, calcium channels, and sodium channels. So you can see why amiodarone is considered as broad spectrum antiarrhythmic drug, because it is having also other three class properties also. First, इसका primary action जो है, the primary mode of action is potassium channel blocker. But now here we can see this is also blocking the beta receptors and the calcium channels and the sodium channels. So further electrophysiological manifestation of this drug effect include decreased sinoatrial node automaticity and AV node conduction velocity. So this does these things, two things also. डिक्रीज करता है एसए नोड का ऑटोमेटिसिटी को, जो इम्पल्स जनरेट करने का होता है उसको, एंड एवी नोड कंडक्शन वेलोसिटी, एज वेल एज this inhibits the ectopic pacemaker automaticity if there are any ectopic foci. Ectopic means the main pacemaker is SA node. Then the impulse goes to AV node and Purkinje fibers and all this way, this is physiological. And few topics are also there, the foci apart from these traditional SA node and AV node, those are called ectopic foci. So this reduces ectopic pacemaker automaticity also. In some instances, these additional mechanism of action can result in unwanted side effects. So these unwanted side effects, mnemonic for this is SHIT, SHIT, S for sinus bradycardia, H for hypotension, and T for torsitis pointis. So you have to remember this. These are the side effects at the cardiac level. Sinus bradycardia, though it is a drug for arrhythmias, the side effect is also arrhythmia. Okay, hypotension and torsitis pointis. So coming back to next slide. Indications and uses of amiodarone. So mostly it is used in atrial fibrillation. One of the most common indications for amiodarone use in acute setting is atrial fibrillation with a rapid ventricular response or a fast ventricular rate. Okay, so we use it in AF. It is particularly useful in hemodynamically unstable patients and patients with congestive heart failure with reduced left ventricular ejection fraction. So what actually happens when the ejection fraction of left ventricle is less, then due to back pressure and the heart is not able to pump the blood to the periphery and to the vital organs, then blood stays back and this causes congestion. So in congestive cardiac failure with reduced LV ejection fraction, who may be adversely affected by negative inotropic or vasodilating effect of other rate controlling agents. So if we use for arrhythmia other rate controlling agents which are vasodilating, then this will worsen the congestive features. So it is used in this condition also. Amiodarone has effectively controlled the ventricular rate and converted to an maintained sinus rhythm in patients with atrial fibrillation and rapid ventricular response. So it will lower down the rate and will convert it into sinus rhythm. Okay, moving to the next slide. Again indications. So it also can be used for the treatment of other supraventricular tachyarrhythmias apart from atrial fibrillation with fast ventricular response. Apart from this, it is used for supraventricular tachyarrhythmias including atrial flutter and refractory AV nodal and AV reentrant tachycardia, commonly referred as SVT. So what we have seen: atrial fibrillation first, second atrial flutter, third refractory AV nodal and AV reentrant tachycardia, which is also called SVT, supraventricular tachycardia, and treatment of ventricular arrhythmias at the level of atria also and at the level of ventricle also, specifically monomorphic VT, then non-torsion dispointis polymorphic VT, which is usually secondary to myocardial ischemia and not associated with prolonged QT. Then also for the as well as for pulseless ventricular fibrillation, okay, and pulseless ventricular tachycardia that fail to convert after CPR, defibrillation and epinephrine administration. So we have to remember the indication. These are very important for clinical practice also. So moving to our next slide. So let's discuss about the doses. We will discuss the dose according to the condition, which kind of arrhythmia it is, and the setting of hemodynamically stability or instability or the life-threatening condition is there. Okay, so stable monomorphic or polymorphic ventricular tachycardia. Remember, we are discussing about the ventricular tachycardia, which is either stable monomorphic or polymorphic. So to begin with, 150 milligram of IV bolus in 10 minutes. हम 10 मिनट में push करते हैं IV bolus of 150 milligram. May repeat 10 minutes as necessary. Then stable monomorphic or polymorphic ventricular tachycardia. The rate is 1 milligram per minute IV for 6 hours. So it goes like 1 minute is equal to 60 seconds and 1 milligram. So in 1 hour is equal to 60 minutes and 6 hours is equal to 360 minutes. So it will go in 6 hour 360 milligram approximately. Then 0.5 milligram at the rate of 0.5 milligram per minute IV for 18 hours. So the basis is we have to give it in 24 hours, जिसमें से हम we give 150 in the first 10 minutes and rest of the amount we give in uh, rest of the part of time, not exceeding 2.2 gram per 24 hours. So the maximum dose you can give is 2.2 gram within 24 hours. Okay, so first you will give 150 milligram IV bolus, then you will give for 6 hours 1 milligram rate, then 0.5 milligram per minute for another 18 hours. For breakthrough episodes of VF, if the rhythm is converted to sinus rhythm, in spite of this also, if there is breakthrough episodes of ventricular fibrillation or hemodynamic unstable VT, repeat the initial load. So again we will repeat the 150 milligram. So I hope it is clear to you. Moving to the next slide. Now pulseless ACLS, pulseless ventricular fibrillation or ventricular tachycardia. So ACLS, pulseless ventricular fibrillation or ventricular tachycardia, we use this way: 300 milligram IV or intraosseous push after dose epinephrine if no initial response to defibrillation. So if we have used defibrillation and there is no the sinus rhythm restored, then we give 300 milligram of IV or intraosseous. So usually in ICU setup, we use in tertiary care, we use it as IV. I have never seen any case of intraosseous administration. Mostly we use IV. May follow initial dose with 150 milligram IV for 3 to 5 minutes. Dosing consideration. Rapid IV pushes if pulseless or no BP. So this is a condition, acute condition. We have to restore fast. So we give it rapid IV. Okay. Moving to next slide. Life-threatening ventricular arrhythmias. So here we are mainly discussing about the adult doses. About 1 gram over first 24 hours. So in previous slides we have seen maximum of 2.2 gram in 24 hours you can give. So here about 1 gram over first 24 hours we have to give. Dose is given in a 3-phase sequences. So this is very important. Let's discuss this. Initial rapid loading dose, then slow loading dose, then first maintenance phase. So what we do in initial rapid loading dose, infuse 150 milligram at a rate of 15 milligram per minute. Initial infusal rate should not exceed 30 milligram per minute. Remember this. And followed by a slow loading phase. Infuse 360 milligram at a rate of 1 milligram per minute. Followed by the first maintenance phase. Infuse 540 milligram at a rate of 0.5 milligram per minute. So you can remember this. Remember 3 stages: initial rapid loading, slow loading, then first maintenance. I have highlighted them with blue, yellow, bold digits. So first you need to remember the digit 150, then 360, then 540. First it is 15 milligram, maximum up to 30 milligram, then at a rate of 1 milligram, then at a rate of 0.5 milligram. So this is very important. After the first 24-hour maintenance infusion rate 8.5 milligram per minute, that is 720 milligram over 24-hour rate may be increased to achieve effective suppression of arrhythmia. For breakthrough episodes, supplemental doses of 150 milligram may be given at 15 milligram per minute. May repeat supplemental doses up to a maximum IV dose of 2.2 gram 24. As we have discussed earlier in earlier slides, also there are also in that setting also it was maximum within 24 hour 2.2 gram we can give. And here in life-threatening condition tachyarrhythmia, we are giving in 3 phases. You have seen rapid loading, then slow loading, then first maintenance phase. Okay, may repeat supplemental dose up to a maximum dose of 2.2 gram per 24 hour. Maintenance infusion it up to 0.5 milligram per minute may be continued for up to 2 to 3 weeks with caution. Okay, then moving on to next slide, ventricular arrhythmias. So here we will see a peroral route and IV route. Peroral route, the loading is 1800 to usually 1200 or 1600 milligram per oral for 1 to 3 weeks until response. Once adequate arrhythmia control achieved, reduce dose to 600 to 800 milligram per day for 1 month. Then reduce the maintenance, then reduce the to maintenance dose. So first we give loading dose in which usually 800 to 1200 or maximum 600 milligram you can give for 1 to 3 weeks. Once the arrhythmia settle down controlled, then we shift it to 600 to 800 milligram per day for 1 month. So first 1 to 3 weeks, then for 1 month. Dose in the maintenance phase would be 400 milligram per oral. Okay, then in IV route we will give, so we have seen we can give it per oral, we can give it IV and intraosseous. 150 milligram over first 10 minutes with 15 milligram per minute की rate से, then followed by 360 milligram over next 6 hours 1 milligram per minute की rate से, then 540 milligram over remaining 18 hours. So here also we are giving in 6 plus 18 24 hours. So first we are giving with initial 10 minutes 15 milligram 150 milligram, then for 6 hours 360 milligram we are giving, then remaining 18 hours we are giving 540 for a total of 1 gram is equal to 1000 milligram over 24 hours before administering maintenance infusion. So loading dose we give for 24 hour in 3 dose in 3 divided like this in 3 divided forms and 1 gram total. Maintenance is 0.5 milligram minute per minute for a total 720 milligram per 24 hour at a concentration of 1 to 6 milligram per minute. Okay, Then duration of therapy may continue to administer 0.5 milligram per minute for 2 to 3 weeks regardless of patient's age, renal function or ventricular function. Okay, moving to the next slide. Now the most important part, which is oftenly asked in various NEET PG exams, AIIMS and PGI JIPMER also, side effects of amiodarone. Okay, so first in general we will discuss what are the side effects, then we will see along with the mnemonic. Okay, so I have also included the images of the side effects so that it gets registered in visual cortex and you can remember and recall it for a longer period. So blue grain discoloration of skin. So usually those patients who are chronically dependent on amiodarone, that are, if they had called generalized blue color of the face, they are called blue men also. So we will see the pictures also. And other is photosensitivity, peripheral neuropathy, paresthesia, myopathy, ataxia, tremor, nausea, vomiting, metallic taste, hypothyroidism and hypothyroidism. This is very interesting since the drug amiodarone contains iodine. So it is also seen in many cases it causes hypothyroidism also and hyperthyroidism also. So baseline thyroid profile to be done is important before you start the amiodarone in a stable patient. Alopecia, sleep disturbances, corneal microdeposit, hot flushes. So let me tell you, the most common side effect of amiodarone is corneal microdeposits. In chronically use those patients who chronically use amiodarone, in 90% cases it has been observed that corneal microdeposits are found there. And then sweating, heart block, bradycardia, sinus arrest, hepatotoxicity, and heart failure. Okay, moving to the next slide. Potentially side effects. So mainly potential side effect includes lung. Pulmonary toxicity include pulmonary fibrosis and interstitial pneumonitis, hepatotoxicity, thyrotoxicity, ventricular arrhythmias, pulmonary alveolitis, exacerbation of arrhythmias, and rare serious liver injury. Generally in patients with high dose and having pre-existing abnormalities of diffusion capacity. Okay. So, if we specifically discuss about the pulmonary toxicity, which typically presents in the first year of use and most commonly resemble interstitial lung disease, which is also called ILD. So, the feature of amiodarone toxicity resembles interstitial lung diseases. However, pulmonary toxicity also can present as organizing pneumonia, pleural effusion, acute respiratory distress syndrome, or diffuse alveolar hemorrhage. So, these are the 4 to 5 presentations in a patient using amiodarone, in which pulmonary toxicity can be seen as interstitial lung disease, pulmonary organizing pneumonia, third is pleural effusion, acute respiratory distress, which is also called ARDS, which is a very critical condition for the patient, and also diffuse alveolar hemorrhage or alveolitis. Okay, so you need to remember this. Now we discuss the mnemonic for the side effects. So this part is the most important part of the whole slide. Periphery of my lung liver. This is very famous mnemonic. Many people use this. Periphery of my lung, liver, cornea are photosensitive हैं. So you need to remember this line. Many of the side effect will be included and will be remembered as per this mnemonic. So let's discuss this. Periphery means peripheral neuropathy and P for paresthesia. Okay. Then off. O for, you can remember O for ocular features. Ocular side effects include photophobia, optic neuropathy, and visual halos. Baseline ophthalmological evaluation is recommended for patients starting amiodarone. Then my for myocardial side effects, that we will discuss under the cardiac side effects separately, and my for myopathy, then ataxia, tremor, nausea, vomiting, metallic test, GI side effects means. At the level of lung, pulmonary fibrosis, interstitial pneumonitis, pulmonary alveolitis, and hemorrhage, interstitial lung disease, that organizing pneumonia, we have already discussed this in detail under the fatal complication or the fatal side effects. Then in liver, it is hepatotoxicity, raised liver enzymes are seen, so frequently the patient has to get done with the liver function test. Then cornea, most common side effect is, as I told you earlier, corneal microdeposits are the most common side effect which occur in at least 90% of patients taking amiodarone. This is thought to be due to the secretion of amiodarone in the lacrimal gland, which with uptake by the corneal epithelium. So If the next level of difficulty the people ask you, then they will ask you the mechanism why it is there. So we are just remembering this, as the amiodarone in the lacrimal gland is secreted with uptake by the corneal epithelium. Okay. R A for alopecia, hair loss. Then photosensitivity. Okay. And last word is hai, periphery of my lung, liver, cornea are photosensitive hai. H for I have considered here, usually the mnemonic goes like periphery of my lung, liver, cornea are photosensitive, and I included hai also. So H for heart. So you can see ventricular arrhythmias, exacerbation of arrhythmias, heart block, bradycardia, sinus arrest, and H for hepatotoxicity, H for heart failure. So this is the most important part of the whole slide. So you need to remember this anyhow. Okay, so moving to the next slide. So here I included few pictures so that you can have a visual memory. So top to the bottom, here you can see eye ke level pe cornea, then thyroid, here corneal micro deposit, which is also the most common. Thyroid hypo and hyperthyroidism both are seen because the drug amidon contains iodine. Okay, then lung 5% seen, we have seen already, organizing pneumonia and interstitial lung disease type pattern, and pulmonary hemorrhage, and in severe cases acute respiratory distress syndrome also seen, alveolitis also seen. Okay, in liver hepatotoxicity, res liver enzyme, and in skin blue men, like blue gray pigmentation we have seen. GI में uh, nausea, vomiting, and metallic test. Neuromuscular में ataxia, myopathy, ataxia and myopathy. And this we see sodium, potassium, and calcium channels, beta receptor density. So it works on all the levels. Then it is used in atrial fibrillation and ventricular arrhythmias. Okay, so this is very informative slide. Moving to the next, this is again same. So yeah, so here also at the level of heart, bradycardia, heavy block, thyroid, hypo, hyper, skin blue gray, photosensitivity, liver elevated enzyme. See, you can see AST or ALT is more than 2 times than normal. We also can see hepatitis and cirrhosis. We have seen blurring, photophobia, halovision, optic neuropathy, GI or anorexia, nausea, tremor, ataxia, insomnia. So for thyroid you will do thyroid function test. For skin you will do routine physical examination. For liver you will do LFT or liver enzymes. For eye you will do slit lamp and eye examination. For GI history will be sufficient, and for CNS physical examination the history. So there is the incidence, as you can see. Eye you can see more than 90% it is affected. Okay, and skin is also affected in 25 to 75% cases. Okay, so let's move to, I hope I have seen, yeah, we have seen 3 to 4 slides. Yeah, so hope this is very clear to you, you will not make mistake in this question. Okay, so this is very beautiful to remember. I used to do 2 things, extensive theory studies along with questions. Then I used to make mnemonics, and then I rely more on visual memory, so that if you remember, if you see it first time, and you can remember it longer. So uh, you can see this main is having blue gray pigmentation of on skin. So you will never forget again. Amiodarone causes blue gray pigmentation. Then you can see here feature of ILD and fibrosis lungs. This is the X-ray of a patient using amiodarone, lung fibrosis in ILD you can see, and these pictures. And this is corneal microdeposit. Okay. Then this is torsidis pointis. Okay. This can be asked as a separate question. So amiodarone causes torsidis pointis. This is the ECG. Now coming to the drug-drug interaction, let's see what are the drug-drug interaction. So this is potentiation of antiarrhythmic drugs. If you are using another class of antiarrhythmic and you use amiodarone along with it, then this causes potentiation of the other antiarrhythmic drugs. Possibly increased risk of adverse effect when used with anesthetic agents, okay, like lignocaine, etc., which is also antiarrhythmic. Monitor plasma levels of amiodarone when used with HIV protease inhibitors. Cimetidine may increase serum level of amiodarone. Concurrent use may increase serum level of cyclosporin and may increase the risk of myopathy or rhabdomyolysis when used with HMG co-reductase inhibitors. And rifampicin may reduce the serum level of amiodarone. So you have to remember the other antiarrhythmic drugs if you are using which can potentiate it, which can be potentiated by this drug class of drug, and you need to see be careful if you are using HIV protease inhibitors, cimetidine, and these HMG co-reductase and rifampicin. Okay, moving to the next slide. So drug interaction which is potentially fatal, potential the effects of warfarin and other anticoagulants. Hence, dose of warfarin generally needs to be reduced approximately to the half, and raise the plasma concentration of digoxin, phenytoin, and quinidine. So you need to remember digoxin. So mainly when we have seen this in patients with low ejection fraction, we use digoxin, and phenytoin is anti-epileptic drug again, and it is also antiarrhythmic, and quinidine. So additive effect with beta blockers and calcium channel blockers. Example, verapamil and diltiazem. We have also seen that amiodarone has a broad spectrum of activity. It also works on beta adrenergic receptor and calcium channel and sodium channel. Now, amiodarone and related to pregnancy, it is teratogenic effect class D drug. It is considered neonatal hypo or hyperthyroidism it can cause. Cardiogenic shock, severe sinus node dysfunction causing marked sinus bradycardia, second or third degree atrioventricular block, and when episodes of bradycardia have caused this syncope. Pre-excitation, so pre-excitation, Wolff Parkinson White syndrome, and concurrent atrial fibrillation, hence used in conjunction with a pacemaker. When, sorry, there is the blue, so when used in conjunction with a pacemaker. Hyperkalemia and sodium channel blocker toxicity, such as in tricyclic antidepressant. Bupivacaine and quinidine toxicity may produce arrhythmia that resembles VT.